And now we're delighted to have a public talk from Professor Anita Thapar, our distinguished colleague, on young person's mental health lessons from research. And I don't think there's anybody I can think of who would be better placed to give such a talk. So we're really looking forward to hearing it, Anita. Thank you very much.
Thank you, Jeremy, for the introduction, and thank you to all of you for coming to join us. We're very excited about the centre. Just a bit of background. I'm trying to aim this at everyone, so scientists, forgive me. My background is I've been a child and adolescent psychiatrist for over 30 years, and I'm also a scientist. So with that, I will share my slides.
And just to say, I think there will be an opportunity to place a few questions in the question and answer box for Anita. So we'll try and keep an eye across those as well. Over to you, Anita. That looks perfect.
Brilliant, you can all see it. Fantastic, that's a good start. Well, welcome everyone to the second half of this afternoon. I don't think anyone needs to be uncertain about are people taking children and young people's mental health seriously. It's everywhere across our news, and it is a really important topic. But I just want to start off by saying, well, actually, what do we mean by mental health? And I think, particularly as a psychiatrist, I'm really aware that this encompasses a huge spectrum. So on the one hand, we've got mental well-being, where young people are thriving, but then you can have a few symptoms, feeling a bit depressed or anxious, but you're coping. Then these can become more persistent, where people are struggling. And actually, if these carry on, people can become extremely distressed and this is where we start calling things a disorder, and where you start needing specialist help. So it is a whole spectrum, but sometimes people forget about this. We are really familiar with it for physical health. So we all accept that sometimes we have hiccups in our physical health, coughs or sniffles. Sometimes those will get really bad, and it might be difficult to go to work, and we might need to see someone about it. And other times people get really unwell and they need specialist treatments. So I think the best way of looking at mental health is as a spectrum. And as I said, sometimes people forget about this. The other thing is that there are many different types of mental health problems, and they tend to come in at slightly different ages. So neurodiversity, autism, ADHD, we call these neurodiversities rather than mental disorders. They tend to start very early. And you've got anxiety, which comes in from childhood onwards, eating disorders through adolescence and depression, and bipolar disorder and schizophrenia that come on a little bit later. Now, so many of us tend to think of these in silos, really separate. You know, clinicians who say, right, well, I actually am an expert in ADHD or eating disorders, and our services are like that, and the research is like that. But one thing that we have learned from research is that there's rarely one type of problem. Anyone who's a practitioner will already know this, that actually when we see people, there's overlapping sets of problems. And actually we can't look at these as separate and in silos. Not only do they show overlaps between each other, but we've also learned that the predominant difficulty might change over time. So for example, somebody might have autism as a child and then as a teenager develop depression. And so one thing I really want to emphasize is that these overlaps are really important. So why is there so much more concern about young people's mental health? We've heard this from quite a few different people. Well, first of all, the research has shown that there are more young people with a mental health disorder than 20 years ago. The biggest increases, particularly in recent years, as Paul Ramsbottom said, anxiety, depression, and most recently, eating disorders. And for those of us who work in specialist CAMHS, obviously this has been reflected in huge increases in referrals. And it's not just because of that. Also, in the last 20 years, we've had changes in service configuration of going between up to 16 to up to 18. And 16 to 18 is a peak age of onset for many mental health problems. These are the latest UK-based data. It's from a mental health survey done across England, but the demographics will be quite similar for many parts, rest of the United Kingdom. So in blue, we have the rates in 2017, and in orange in 2021. So the age 11 to 16-year-olds, you can see that the rate has gone up just even in those years since after COVID, and age 17 to 19, also a huge increase in mental health problems. And this is probable mental disorder. So this is right at the other end of the spectrum. So apart from the increase in rates of mental health problems, there are other really important reasons to be concerned about young people's mental health. Apart from being hugely disruptive for the young person themselves, particularly if they're in school, for their families and everyone around them, it's also relevant to the whole of society. Even if you don't know a young person, or you don't, I mean, I've got 2 boys myself, but even if you don't have boys, because actually of all the mental health disorders across adulthood, nearly all of them have originated before the age of 25. So if we want to do something about mental health disorder across all ages, we need to focus on young people. And the earlier the onset, the worse the outcomes. So it really is important to begin early. So as I've mentioned, there are many different types of mental health problems and they're overlapping. Our centre will focus on anxiety and depression, but we will not look at this in isolation of all the other types of difficulties. But for the purpose of this talk, I'm going to focus on depression. So depression, like mental health problems, encompasses a really huge spectrum. We can refer to it as a mood state, and which of course is absolutely typical, normal. We all have fluctuations in mood, days when perhaps you feel a bit sad or worried, but actually you're coping. Then that you can have low mood, which comes with a cluster of other difficulties. Loss of interest, just for example, a young person who's no longer interested in going out with their friends, not enjoying, perhaps they had an interest in sport, no longer enjoying that, finding it difficult to concentrate, which of course is a huge problem in school, sleep, appetite, becoming distressed and other people may be getting concerned. And then if it stays persistent, that cluster of difficulties, and it interferes with daily life, we then start calling that a disorder, major depressive disorder, and all these are accompanied by multiple risks. So we do have to take it seriously. We've talked a lot about Wales, and of course we are based in Wales, but just to highlight that depression is actually a leading cause of global disability. And actually, just a word of reminder, because most young people are in low and middle income countries, most of the burden is there. But of course, we have it everywhere, including here in the UK and Wales. Depression is actually set to become the world's leading cause of disability. That's looking at all health problems by 2030. So it is actually a global issue. What have we learned about depression? We've learned it nearly first onsets in adolescence. It's more common in girls and women, but it's important to recognise, because of that fact, it may be missed in males. And that's really quite important to remember. And across all countries, not just the UK, rates of major depressive disorder, that's the severe end, have risen in young people. So a really big question is, why has depression in young people increased over time and across countries? Everyone speculates about why that might be so, but you actually need really robust scientific approaches to do this. And this is going to be the work of Wolfson Workstream 1, led by Stefan Kolishul. So the next question is, if you really want to prevent depression, what causes it in the first place? Well, we know we've learned in the last 20 years, it is never one risk factor. It's multiple risks that all add up together to create risk for depression. And these, of course, could be modified by the action of protective factors. People sometimes think, well, the social experiences have got nothing to do with brain, but actually, again, what research has shown is that risk factors such as being bullied, living in very stressful early environments result in brain changes. And what we see when we see people is that this can alter ways of thinking and alter people's behaviours, which then can lead to depression. There are multiple risk factors associated with depression, and I'm sure this isn't a full slide, you could get even more. We know there are some things which are specific to young people, so having somebody else in the family with a mental health problem or genetics. There'll be some which affect the individual, such as having a chronic long-term physical illness, being neurodiverse, having anxiety is also a risk for future depression, and then encountering very stressful circumstances like being bullied or getting involved with having a really problematic relationships or very stressful events. And we also know that broader types of stressful situations, such as perhaps living in poverty, certain minority groups, we know, not all minority groups, but certain minority groups at increased rate. So what I've done is I've highlighted double asterisks where we've got good evidence, one asterisk where we've got reasonably good evidence, and there are some you can see there that aren't as robust. So there are so many different factors that go together with depression, but we don't necessarily know that these genuinely are causes. For example, some of these things may just arise because the person is depressed already. So if somebody's depressed, they may start not seeing people. But it's really important. Why is it important to identify genuine causes? Well, we all know that cigarette smoking can lead to lung cancer, and it can also lead to heart disease. Because we've learned that, we've really cut the rate of smoking in many countries, and the rates of heart disease have fallen in some places. However, if you get the wrong risk factor, you could be just wasting your time with prevention programs. So for example, vitamin E was thought to prevent heart attacks. That's now been shown not to be the case, so there's no point in taking it. So we need to do that for depression. We need to reduce harmful risk, increase protective factors, and it's also helpful looking at risk factors because particularly if you are working with young people, perhaps in schools, or you're a practitioner, being able to identify groups where you might feel a little bit more concerned about them. So a big question for the Wolfson Centre is actually identifying what causes depression in young people to inform prevention programmes. So workstream 1, led by Stefan, is using data from across the UK, which has tracked people from birth to adult life. And workstream 2, led by myself, you might not everyone might know this, but you can actually use genetic techniques to identify social and environmental causes. And that's what we'll be doing. So what could help the spectrum of depression? So if we go down to this left-hand side with low mood, having increased knowledge and awareness of depression in young people is important, and knowing what sorts of self-management skills would be helpful. For example, we know that sleep is important, engaging in pleasurable activities, and certain behaviours are harmful. What sorts of being able to harness support from people around the young person. We also know from research that actually improving the school emotional climate, so pupils have a bigger say in their schools and you've got warmer, more supportive relationships, also helps. So that's one place to start. If, however, you've got low mood with a cluster of many other difficulties, then it's important to recognise that this is becoming a problem. So you have to recognise, be able to provide early intervention, and ideally now prevent this from actually going on to disorder. And finally, for the really more persistent difficulties where there's an interference with day-to-day life, then we're thinking actually about intervention. So work stream 4 is actually all about that first left-hand side, detecting and recognizing depression. We're going to develop an evidence-based toolkit for schools with our colleague who you saw earlier in New Zealand. Also, a self-management web-based tool, which is being led by Rhys Bevan-Jones. And also our colleagues, this is work led by Simon Murphy and Graham Moore, will be evaluating what works in schools across Wales, because the data on all schools and pupils is there, by testing the effects of new policy changes, the whole school approach. So moving from the very earliest stages, what about early intervention and prevention of disorder? Well, the commonest risk factor is actually having a parent who's got a history of depression. It's estimated at least around 4 million children and young people are exposed. I just want to say that many, however, with a family history, or even if they're exposed to a risk factor, can show resilience. It's not inevitable. And some of the research from our group has actually shown what can enhance resilience. Risk isn't inevitably leading to difficulties. So what research has shown is that actually, I've shown this before, if a young person who's at risk of depression is given a psychological intervention which tackles their altered ways of thinking and altered behaviours, that can help prevent depression. But then research has also shown that that does not work so well if if his or her parent is currently depressed. So how can we help prevent depression in a high-risk group where 2 generations have depression? Well, we are going to be using a novel cross-generation approach. This is Wolfson Workstream 3, the intervention led by Fran Rice, which will involve a psychological prevention programme where there'll be intervention for parent and the young person and identifying exactly how it works. So let's move now to the far end, the right of the spectrum. What about depression that is a disorder? So here I'm talking about low mood, many other symptoms that persist and where young people are having problems in their daily functioning, maybe getting to school, engaging in the usual activities that they would do. And here you're thinking about intervention or treatment. So what are the current guidelines now? And I'm talking about the UK guidance, which comes from NICE, for treating major depressive disorder in young people. So one of the first things that we've learned from research is that some young people, particularly with milder depressive disorder, will get better spontaneously. So we don't need to rush in straight away. We need to ensure that the young person is safe, that they've got good support, and that any harmful risks are minimised or removed and protective factors are increased. But if depression is severe, persistent, there are risks, for example, self-harm, family history, or other stresses, then you have to move to intervention rather than wait. So what interventions for adolescent major depressive disorder work? Now it's funny because I'm a psychiatrist. Sometimes people will say to me, oh, nothing really much works. And that's a real problem because that is absolutely not correct. We have a lot that works. And actually for scientists who've looked at how well interventions work for mental health versus physical health conditions, they're pretty equal and some of them are better. So actually that's really important to realise that. And I think that's sometimes why, I mean, obviously it's wonderful that the Wolfson has funded this, that people think, well, it's maybe not worth funding because you can't do anything. That's absolutely not right. So the first line intervention that's recommended in the UK is psychological talking therapies. And they work very well for milder depression and they work very well for some people. Not for everyone, of course, if the social context is very difficult, that has to be addressed. These psychological therapies basically target your thinking, behaviour, and how you relate to others. And for those who are interested in what these interventions are called, here's a list of them. And any one of these can be used, but of course the practitioner will try and match what of these talking therapies may seem better matched to the individual and their family and social context. What about moderate to severe major depressive disorder? So this is much more severe, it's really persistent. So again, I just want to emphasize, we do not use medication on its own, at least that is not recommended. You choose a psychological intervention according to the age, that's what's recommended. And then for the very severe and where it's not responded in a psychological intervention, you add in an antidepressant. Now we have had very few treatment trials for the under 18s, just generally. I mean, my colleagues in pediatrics will say the same, it's not just mental health. There's only one antidepressant medication which is approved for under 18s in the UK, that's fluoxetine. It has to be administered by a specialist and monitored carefully. And actually, if fluoxetine doesn't work, there are a couple of others recommended, but we don't actually have the research for that yet. I'm going to tell you a bit, though, about what happens in real life, because nobody is the same. And one of the things I wonder is, should we call depression the depressions? So if you think about it, depression is a bit like calling a bowl of fruit, fruit. And I'm sure all of you will agree that a grape is nothing like a banana. There are commonalities, so it's obviously helpful to learn, but actually every type of depressive disorder is different. And that is really quite a challenge. Just to highlight, this is not peculiar to mental health. It's the same in physical health. So, for example, person 1 could have completely different types of depression symptoms from person 2, but they've both got a major depressive disorder. Person 1 might have ADHD or autism, person 2 isn't, but has had long-standing anxiety. The other way that can differ is some people may start having depression right at the beginning of their teenage years, others as they're getting into sixth form or later. So there's huge variation, or even later on in their 20s or later still, there's variation of age of onset. Social contexts are hugely variable. And also, whether or not people have a family history is variable. So some people have a parent who's had depression or bipolar disorder. Other people, there's nothing at all in the family. Some people have had exposure to really a lot of adversity all through their life, and others is just come out of the blue. The other really complicating thing is somebody could have depression and another person have depression and they have completely different outcomes. So some people will just get better and that's it. They'll never get another episode of depression again. Others will get better, but then have another episode in maybe a couple of years' time. And yet others may develop a different sort of mental health problem in the future. So you've got hugely variable outcomes. The other thing for anyone who's known somebody or perhaps themselves had any sort of intervention is different things work for different people. And at the moment, it is trial and error to find out what works for each person. And that's very frustrating for the person involved and for the practitioner. So Wolfson stream work streams 2 and 5 is how can we make our management of major depressive disorder more personalised and trying to sort of make sense, if you like, of this bowl of fruit. And what we're going to try and do is identify different depression subgroups using huge data sets with genetics, clinical profiles, social data and outcomes. And this is where a global perspective is really helpful because we're fantastic. We are so lucky in Wales. We've got all these data in Wales by NHS and schools, but we'll also be working with colleagues who've got really large data sets in Norway, Sweden and Denmark, also large data sets from the United States. And finally, is that scientists have put together quite a lot of data sets from all around the world, just to emphasize these are all anonymized. We don't know who any of the people are, but it does make us then able to work together to identify different depression subgroups and making it more personalized. So just to summarize, I've given you a very brief overview of mental health and depression. I hope that if you take one message away, mental health problems and depression span a spectrum of severity. And I think that's really important, because sometimes we say, oh, well, if we do this, we won't need CAMHS, or actually, if we have CAMHS, we don't need to worry about schools. We need it across the spectrum. They do span a spectrum, and we need to look at the whole spectrum. It's complicated, and we're going to need many different approaches. It isn't going to be a single approach. Policy changes, prevention, early intervention, and more tailored treatments. The really common pitfall is to think, oh my gosh, adolescent mental health problems, the rate has gone up. We're only going to focus on adolescents. But hey, adolescents are children before they become adolescents, and young children. And actually what research has shown is that you've got to look across development, and the earlier, the better. The other thing is adolescents, young people are not living in isolation. The top right-hand corner, some of you may recognize this. They live in systems, in families, in schools, in communities. There may be cultural contexts. Not only that, as I've already highlighted, we've got huge overlaps between the different types of mental health problem. Because of the prevalence, the increase in it, mental health of young people really needs to be a priority for everyone, not just researchers, but for those who are offenders, for those working with young people. It needs to be for us as a society. It cannot be one person highlighting this. And I think one of the young people mentioned this, which I think is really important. It's very tempting to think, oh, mental health is straightforward, because everyone has a few mental health symptoms and we know what has to be done. But our most important thing is not to cause harm. What we do needs to be informed by research, and central to all of this has got to be the voice of young people. And with that, I thank you for your attention. Diolch yn fawr.